blood, right? Like we discussed earlier with the whole nephron thing. I'm not going to draw the whole thing. Well, maybe I will. I don't know. You have 1 million of these nephrons in each of your kidneys, okay? And within the what we call the Bowman's capsule, you have something called the glomeruli. And the glomeruli is really important because it receives all the body's blood into this area, and then all the waste that we have that we don't want passes through. We're good with that, correct?
Yes.
We have about 1 million of these nephrons in each kidney. So we have 2 kidneys, and we have about 1 million of those nephrons that filter blood and remove waste and maintain fluid balance and maintain electrolyte balance and keep the waste in our blood at a minimum so we don't have any toxicity in the blood. This is what the nephrons do. You can have 2 types of kidney failure, okay? You can have your acute, and your acute kidney failure is pretty interesting because do you remember these 2 drugs, metformin, not 2 drugs, but metformin and your dye? Do you remember any discussion about that?
No.
Metformin is a type 2 diabetes medication, and that puts a strain on the kidneys. But if you're a healthy individual, metformin, your kidneys, it can do just fine with them. But if you introduce a contrast medium, a dye, which also puts a strain on your kidneys, if you have both of those together, that equals acute renal failure. Your kidneys will shut down because it's too much stress that's being loaded onto your kidneys. Does that make sense?
Yes.
So in other words, where the chemicals of metformin and the chemicals of the contrast medium, when they pass through the kidneys, through the nephrons, those nephrons, they shut down. And so the patient can develop acute renal failure, meaning that all their kidneys are no longer functioning. Does that make sense?
Yes.
Keep in mind that acute renal failure has 3 phases. The first one is when, something that makes your kidney shut down. It doesn't necessarily have to be metformin and dye. It could be anything. It could be that you got shot and the renal artery is no longer sending blood to the kidneys shut down. So during the initial stage or the first stage of acute renal failure, you develop oligarchia, right? What's oligarchia?
Not urinating a lot.
That's correct. Yeah, it's decreased urine output, and the reason why your urine output decreases is because you have less blood supply to the kidneys, caused by one of these multitude of issues, right? Please keep in mind that the kidneys should produce at least 30 mLs of urine every hour, and that lets us, the nurses and the healthcare practitioners, know that the kidney has enough blood to create the minimum amount of urine that keeps us alive. Does that make sense?
Can you repeat that part?
Yeah, 30 mLs of urine is the least amount of urine that your kidney should be making. And that lets us know that the patient has the bare minimum of blood supply, that they have good blood supply to the kidneys. So if in an hour they're producing 30 mLs of urine, that means that they have what's needed so the body can maintain homeostasis. Okay. Once that urine output drops less than 30 mLs per hour, we have some issues with the kidneys. There's something going on. So the first stage in acute renal failure is the Aldebaric Phase. That can last several weeks. During this time of the Oligarch Phase, your lab values are going to be abnormal because the kidneys are not cleaning the blood. So you have your BUN, which should be 10 to 20. Of course, it'll be high. You have something called your creatinine. And this is the best blood test to assess kidney function, by the way. The creatinine should be 0.6 to 1.2. But when you have kidney failure, both of these values will be elevated. Any questions on that?
No.
Okay. And of course, you also have other things like something called the glomerular filtration rate. This is how much fluid is passing through the kidneys every minute. And it should be about 100 mLs per minute. It doesn't mean that they're producing 100 mLs. It just means that 100 mLs is what the kidneys are filtering every minute. And that provides us in the hour with the creation of at least 30 mLs of urine out of that 100 mLs of blood that passes through the kidneys. Does that make sense?
Yes.
Okay. So we could also look at GFR and stuff like that, okay? There's also something called the creatinine clearance. This is trying to find out how much creatinine, which is waste, is being expelled from the body in a 24-hour period. And what we do is we collect the urine for 24 hours. And you should know that, let's say the doctor says, start a creatinine clearance at 9 a.m. At 9 a.m., that first void, we're going to flush it. We're going to discard it. And then we will collect all other samples up until 9 a.m. the next morning. And we're going to keep all that urine. You have to keep it cold. So you keep it in the refrigerator after you put it in a biohazard bag. You keep it in a Foley bag with ice in a bucket so you can make sure that it stays cold. Does that make sense?
Yes.
Okay. Any questions so far, Ms. Cervantes?
No.
All right, cool. So again, back to kidney failure. All those lab values are going to be off. We'll discuss more specifics of it in just a bit. But the first stage is the Oligarch phase that lasts several weeks, right? And then after that, your kidney slowly starts to regain function again, and it starts to pee. We call that the diuretic phase. But although the kidneys are producing urine during the diuretic phase, they're still not being able to concentrate the urine. What I mean by that is they're getting rid of water, but they're still not able to get rid of the waste that's inside the blood. Does that make sense?
Yes.
So during this time frame of the diuretic phase, it's important that we continuously monitor the blood values because that gives us an indication how well the patient is doing. And then that'll last a few months, and then the patient gets better. And then the patient goes into what we call the rehab phase. The rehab phase can last up to a year as well, that we wait for the lab values to go back to normal and the kidneys to regain full function. Does that make sense?
Yes.
So as you can see, this whole acute renal failure part, it takes a while. You know, it has this whole course, this time frame that it passes through that the patient must go through. Any questions on that?
No.
When we talk about, we have another type of renal failure. This one happens secondary to chronic illnesses like diabetes, like hypertension, like lupus, other systemic issues where your kidneys are slowly being destroyed. And that 1 million amount of nephrons per kidney starts dwindling throughout the years. Okay. Each kidney, or actually a whole body, only needs about 500,000 nephrons to function. So technically, we only need the half of one kidney to work to maintain homeostasis. But you can imagine if someone has hypertension, those nephrons are dying little by little. If you have diabetes, those nephrons are being destroyed little by little. If you have an autoimmune issue, those nephrons are being destroyed little by little. If you have an infectious condition called glomerular nephritis, your nephrons are being destroyed, and eventually you could develop end stage or late stage renal disease. Does that make sense? When we talk about late stage, all we're saying is that these issues that the patient developed with their kidney, they're not getting better, and they're at the end, meaning that all their lab values are messed up. Very similar to the patient's Oligarch phase in the acute renal failure. The only difference is that in late renal stage, it's not getting better. We call that end stage renal disease. And in end-stage renal disease, the patient, again, it can be caused by diabetes mellitus, it could be caused by hypertension, it could be caused by autoimmune issues. All those things can lead to these type of issues in end-stage renal disease. So when you think of late stage, end stage, it's just talking about that the patient no longer has an ability to maintain a clean blood supply. The kidneys can no longer carry out their function. Any questions so far?
No.
Okay. Let me know when I can move on.
Go ahead.
Okay. So we go back to okay. Let me explain this one a little bit more too, okay? If the patient has kidney failure, regardless as to whether it's acute or late stage, but if they're in the part where their kidneys are not functioning, can they get rid of electrolytes?
No.
They cannot, right? So I want you to understand that the biggest issue with people that have kidney failure, all electrolytes go up. The important one is, of course, potassium, because that one affects what? Your heart, right?
Yes.
But then we also have these other two. We have calcium and we have phosphorus, okay? Now, this is an interesting thing because what's going to happen to both calcium and phosphorus inside the blood when you have kidney failure?
It's going to go up.
They're both going to go up, right? However, if you recall that I said that calcium and phosphorus have an inverted relationship, do you remember that?
Yes.
As soon as the phosphorus and calcium start going up, there's going to be a point where there's a tipping point, meaning that at a certain point when both of them are going up, phosphorus is going to continue to go up, but it's going to cause calcium to go down. Does that make sense?
Yes.
Okay. So when someone has go ahead.
Phosphorus keeps going up and
then
calcium.
Levels start decreasing in the blood. And this causes a problem because it eliminates the calcium in the blood and now your bones become very weak. And this is why people that have kidney failure, they develop osteoporosis-like issues and they will develop pathological fractures.
Okay.
Does that make sense?
Yes.
Okay, good. So keep in mind that patients that have kidney failure, you have to provide adequate diet. What are you going to do with the calcium and what are you going to do with the phosphorus in the diet? Or what are you going to do with either of those?
Give more calcium.
And what are you going to do to phosphorus?
Give less.
That's correct. Can we go back to the question?
Yes.
All right, cool. All right, go ahead.
Calcium.
That's correct. Any questions?
Does the potassium go up?
Yeah, all of them go up. All of them
Okay.
go up, but because of the relationship between phosphorus, vitamin D, and calcium, the calcium ends up going down because it's not being absorbed well. Because the kidneys are also responsible for synthesizing or activating vitamin D, and vitamin D helps with the absorption of calcium. So it's a lot of those things that have to do with one with the other. So you want to give a low phosphorus to prevent the calcium from being pushed even lower, and you want to give a high calcium diet. But you don't, your sodium, low sodium, potassium, low potassium. Does that make sense?
Okay. Yeah. So then the potassium just goes down once they start giving like diuretics and stuff like that, right?
If the kidney still has a little bit of a function, yeah, we can give diuretics, we can give Lasix to get rid of some of that potassium. Yes.